back. Did everybody get a little something to eat? And more to come. Do not worry if you have not eaten. So we have another amazing panel for you. I'm going to introduce them, and they are going to be talking about dismantling the disproportionate impact of chronic disease on Black women. Now, I know this is a highly anticipated topic. First, we are going to talk about our moderator, who will be doing the discussion, Dr. Rulan Parekh. And then she is going to be joined by other panelists. Dr. Parekh is the Vice President of Academics and Clinical Scientist at Women's College Hospital, and she's going to be joined by Dr. Lorraine Lipscombe, who's an endocrinologist and Senior Scientist at Women's College Hospital, Dr. Cindy Maxwell, who has the best title in healthcare. She is the Vice President of Medical Affairs and Systems Transformation and the lead executive at Women's College Hospital, a Black woman. Thank you very much. We are also honored to be joined by the freshly minted doctor. We are adding doctor to her title tonight, Keisha Greene, a registered psychotherapist at Women's College Hospital in the Reproductive Life Stages Department. Please join me in welcoming this exceptional panel to the stage.
Good evening. It's so great to see so many faces, and hopefully you're satisfied after the quick snack that you had. We're going to go on to some really sort of different topics that we just had, and really kind of address the issue that's so important that you all know about, is really this inequities that occur in health, in particular for those with Black women, and how can we actually address the disparities that occur. One of the things that's striking to me, a statistic I heard recently, was that one woman in Canada dies every 22 minutes from heart disease. And what's important to understand is that how does that affect the Black community also, and that hasn't been really well studied. But we do know that many of the risk factors are very common among the Black community, and that includes those of obesity, includes those of diabetes, hypertension, and it's something that we need to address in order to try and mitigate that risk. And what's important is that the Black Health Alliance, if you haven't gone to it already, has a lot of statistics that are really important to know about and really addresses the disparities of healthcare that occur. So this evening we're going to actually be discussing why such disparities occur, the risk factors that exist for these chronic conditions, and then what can we do to dismantle the disproportionate impact of these disparities. And so I'm going to start first with Lorraine Lipscombe and really talk about the statistics about around Black women, and the burden of diabetes is quite stark compared to their counterparts of other backgrounds. And as we know, the incidence of diabetes is actually 2 times higher in those from Africa, the Caribbean, or the Black communities compared to those in the white communities. And the rates continue to increase. Lorraine, could you perhaps speak to why you think this is happening?
Thank you, Rulan, and thank you everyone for joining us today. So, the increased risk of type 2 diabetes that's seen in Black communities has been attributed to a number of genetic, biologic, and social factors, many of which are outside of an individual's control. Some research suggests that it is the genetic and biologic factors that account for the majority of the disparity for diabetes risk in Black populations. For instance, a Black person has a 40% estimated risk of getting type 2 diabetes if they have one affected parent, and that risk actually goes up to 70% when they have 2 affected parents. Now, that suggests that both genetics and early life exposures explain some of that higher risk in these populations. But what about social and environmental factors? We also know that there are many social, environmental factors that disproportionately affect Black communities that can also contribute to the burden and risk of diabetes. For instance, many Black populations are more likely to live in lower resourced and less healthy neighborhoods and communities. They're more likely to have greater socioeconomic barriers, and they're more likely to experience stress due to a combination of things such as the effects of institutional racism and discrimination and many other factors. Now, so these circumstances can make it more difficult for these communities to access resources and make healthy choices. Now, stress can also increase the risk of diabetes, both indirectly through its effects on behavior change, as well as directly through biologic effects on metabolic health. So, these social and environmental so-called determinants of health can have long-term effects across the lifespan of individuals, all the way from early life in the womb to childhood up to adulthood. In fact, early life exposures such as maternal undernutrition, maternal stress, and other factors can actually modify the biology of offspring, placing them at higher risk of developing future diabetes, chronic disease, obesity. And these changes, even if they only were present in early life, can actually continue to have effects right into adulthood and can even be passed on to the next generation. Now, in addition to these early life exposures, there is research to show that persistent social and economic disparities within Black communities can increase the burden of diabetes and add to that increased risk throughout a person's life. And some researchers have actually tried to tease out the effects of those early life exposures versus persistent socioeconomic disparities on risk of diabetes in Black populations. And when they looked at men and women separately, they found that socioeconomic risks and factors have a much greater impact on women's risk of diabetes than on men, such that there is a direct relationship between increasing poverty and increasing type 2 diabetes risk that is predominantly seen in Black women, less so in Black men. So that tells us that Black women are especially vulnerable to those social determinants of health, in addition to early life exposures that might be influencing their risk of diabetes. And this is seen in both US and in Canada.
Lorraine, there's a number of projects that you're doing on gestational diabetes and taking a look at risk of breast cancer. Based on the work that you've done, can you highlight findings among the Black community that you think are important to know?
Thank you. So one area of my research, as Rulan mentioned, looks at the impact and consequences of gestational diabetes, which is a temporary diabetes of pregnancy that often goes away after delivery, but is associated with a higher risk of getting diabetes later in life. And in these studies, we were able to ask women what their self-identified ethnicity and race was. And so we were able to look at differences based on race and ethnicity. And we found a few things. So first, when we think about the social determinants of health, we found that mothers who had gestational diabetes who were Black were more likely to have come from low income, have lower education attainment, and were more likely to be single moms. Furthermore, even though diabetes went away in 70% of our women, Black women were significantly less likely to have the diabetes go away, and they were more likely to have persistent glucose abnormalities after delivery. And we know from the US that Black women are the highest group for progression to type 2 diabetes after gestational diabetes. Now, speaking of looking at these numbers on a more population base, I also do research using our large healthcare databases, which allows us to look at questions on a bigger scale. And these databases are collected in the context of healthcare visits. Unfortunately, even though we can look at a lot of questions, we are unable to look at impact of race and racial differences in these databases because race is not currently routinely collected in healthcare, and it's a real problem. And some of the research I've done, for example, has looked at the impact of diabetes on breast cancer, and we found that women who have diabetes have lower cancer screening rates or have more adverse outcomes due to breast cancer. And this effect is magnified in low-income populations. But it would be really important to look at whether these what the impact of being Black on these differences as well, because we know that breast cancer is a big issue for that community.
Thanks. So it's really thinking about gestational diabetes as a risk for cardiovascular disease, and also as a developing the risk of diabetes later on, and then even the risk of breast cancer. So really important to understand the intersection of all of these chronic diseases.
Right.
And we're going to change tack a little bit to talk now about reproductive health. And so, Cindy, I wanted you to talk about the challenges or barriers that face Black women in the community when it comes to their reproductive health. In particular, to think about fibroids. And in fact, I also learned this just from you the other day, was that fibroids actually occur among Black women 2 to 3 times more likely than those in the other communities. They're likely to have fibroids, develop them at a younger age, have larger fibroids, and have more than others, than other women. And I was wondering if you could talk about rates of hospitalization, which are much higher, and what could we do to understand what you need to do as a patient and advocate for yourself? Like, what are the signs and symptoms that people actually need to think about?
It's a really important set of questions, Rulan, so thank you for that, and it's lovely to see everybody here tonight. I think it may be helpful for us to start with dispelling some myths about fibroids, and perhaps even start with a definition. Many people, many Black women, believe that fibroids are cancer or cancerous, and in rare instances they can be, but in general these are benign growths, so non-cancerous growths that occur in the uterus. And they can be numerous, they can be small, they can be large. And we do know, as you were mentioning a few minutes ago, that Black women do bear a greater burden of disease from fibroids in terms of having more of them, having larger ones, having more consequences as a result of health consequences as a result of having fibroids, and are more likely to experience a decreased quality of life as a result. So what are some of these symptoms that go along with fibroids? So since the fibroids are these growths or benign tumors that grow within the uterus, they can create bulk or mass, and that can create discomfort and quite debilitating pelvic pain, for example. For some women, if the fibroids are large enough, they can rest on the bladder or on the bowel, and as a result, people can have symptoms in their digestive tract or their urinary tract as a result. The pain can be such that you might miss school, or you might miss work, or not be able to keep up with your daily activities. Because the fibroids distort to some extent the shape of the uterus, it often leads people to have quite a bit of bleeding, and we know that Black women are more likely to develop significant levels of anemia or low blood counts as a result of bleeding from fibroids. And we know that there are certain types of anemia that do occur more commonly in the Black population, so for example things like sickle cell disease and thalassemias, and so it is sometimes the case that these conditions overlap to really create significantly risky health scenarios for Black women. Because fibroids impact the womb, so the place where we carry pregnancies, they can impact fertility, and they can also cause early pregnancy losses or miscarriages. And in the instance where one is progressing through pregnancy, there can be higher rates of preterm labor and preterm birth, so that can create consequences for the next generation, of course. With the knowledge that Black women have this increased or more severe presentation with fibroids, we might wonder, well, why is that the case? And I think that some of what I'm about to share with you will overlap a bit with what Lorraine just explained to you a few minutes ago. So we know that risk factors for fibroids include things like hypertension and diabetes, obesity, and that is of course related to diabetes as well, but we know that these conditions are more prevalent in the Black population. And there are some studies that suggest that deficiencies in vitamin D can also be related to the development of fibroids. And so for those of us with more pigmented skin, it may be more difficult to absorb sunlight and to have the effects of vitamin D in our system without supplementation. Thinking though, very early on in life when we are developing in the womb and what potential stressors or things our mothers can be exposed to, we find that there are some answers early on that are literally written into our genes that increase the chances of Black women developing fibroids. So those kinds of stressors include environmental factors, so toxins. There are substances called endocrine disrupting chemicals which interfere with the development of our cells and our genes and can predispose us to developing fibroids later in life. But then there are also those psychosocial stressors, things that may be present as a result of our socioeconomic status, where we live, where we may experience the effects of systemic racism, for example, that create chronic levels of stress. Those chronic levels of stress basically undermine the function of our hormones and impact how our genes develop, and also can predispose us to developing fibroids later in life. So when thinking about how to address this, so as a Black woman presenting to a doctor's office to talk about symptoms, it's important to make sure your voice is heard. So to speak up, to not be, don't be dismissed in terms of your symptoms. I heard in the earlier session somebody asking how do you get people to listen to you? How do you communicate? And so this may be one of the situations where you bring a friend, an ally, a support person, a health coach. There are Black doulas in our community who provide not only pregnancy and labor and delivery support, but actually will accompany people to medical visits and fill in some of those gaps that occur in our health journeys. And for those of us who are healthcare providers, who are allies, who are researchers, don't minimize the symptoms of Black women. Don't dismiss them. Make sure that you keep your humility about you as you listen to what people are thinking about and what people are experiencing in their health. And then finally, there are some societal factors and things like environmental justice and the water that we drink and the food that we eat, and potential for environmental toxins to get into our systems, which require bigger answers and responses at organizational levels. But that's an overview of what fibroids mean in general, but also what they mean to Black reproductive health.
And Cindy, you were mentioning to me that the rates of hysterectomy are so much higher among women who are Black, specifically for treatment of fibroids. But we know that once you have a hysterectomy, that there's a whole cascade of issues that happen because of early menopause. And so I was wondering, could you talk about certain therapies, and how can people self-advocate for themselves to make sure that those choices are more appropriate?
Very important questions. The surgery called hysterectomy, which is the removal of the uterus, is a pretty extreme operation, and it may be that for certain people, so for certain Black women who have fibroids, that might ultimately be the correct choice in terms of their treatment. But one size doesn't fit all. And so the key thing, I think, for a Black woman who's going to talk about fibroid symptoms would be to decide or to understand what are the symptoms that are bothering you the most. So is it that you're having so much bleeding that you can't get to work, that your life, your quality of life is declining? Is it more that there's pelvic pain, there are symptoms of the bulk or the mass of the fibroids that are really bothering you? It's helpful to know what are the issues that are important to you, so that your healthcare provider can try to tailor a solution that is specific to what your needs are. So in many cases, there are several steps or several kinds of treatments that can be tried initially to see if you can control symptoms and improve quality of life. So for example, if bleeding is the major issue, so heavy periods and ongoing bleeding which leads to anemia, there are medications such as NSAIDs, so different types of pain relievers, for example, that can help decrease the amount of bleeding. Oral contraceptives. There are IUDs, so intrauterine devices that have some embedded progestin or progesterone, which can help decrease bleeding. So there are many ways to potentially address that particular set of symptoms. On the other hand, if it's really pain and bulk and discomfort related to the number or size of fibroids, there are medications that can target the fibroids and their size and halt their growth. So, for example, there is a group of drugs, they're called GnRH agonists, which can be used for a short period of time, but really can be effective in controlling the size of fibroids and perhaps maybe prevent somebody from needing surgery ultimately, or may help them have an easier surgery if that's what's needed later on. They can only be used for a certain period of time because they do create quite a few menopausal symptoms and can also thin our bones, so we do have to be careful with those medications. There are other medications also that work specifically on a type of hormone that impacts the growth of fibroids, and those are called progesterone receptor modulators. And those medications have a pretty fast onset of effect and can be used to control the growth of fibroids for longer periods of time. So there are many options that can be considered. When it comes to surgical intervention, it might be that rather than having a hysterectomy, having a targeted surgery just to remove the fibroid could be done, so that's called a myomectomy. There are also techniques called ablation, which basically sort of shrink or sort of decrease the size of fibroids with heat. There's also a procedure called embolization, which is really kind of a neat one in that you can have a treatment which blocks a blood vessel that's trying to feed or support the fibroid through a technique that goes through your vein, basically. So it's really not a surgery per se in the classic sense. So there are all these different ways to approach the treatment. The fact that there are so many hysterectomies done in Black women for fibroids is disturbing, of course, on many levels. But when we think about it and maybe step back a little bit, one of the indirect effects of this is really control of Black bodies, control of reproductive potential, and I think that these are themes that we've seen throughout history. So I think, anyway, I feel very sensitive about that particular aspect of this discussion. Resources. Again, having an ally or somebody to take with you as you go through different options for how you might want to have your fibroids treated is important. We have wonderful community resources and advocates. I think some of them are here tonight. So for example, Womb Care. Womb Care is an organization, is a wellness and health organization that focuses on Black women and BIPOC people and reproductive health. There's the Mommy Monitor, which is a virtual health platform, and it provides patients, or it provides Black women the opportunity to connect with providers and health resources within the community and provide that type of support and guidance through the healthcare system. There is also, I mentioned doulas or health coaches, so there's the Ontario Society of Black Doulas who provide many services that fill in, again, those gaps that we might encounter in the health journey. So, we're not alone, we're empowered, we do have those resources, it's just a matter of knowing who and where they are, and I think that's what we're here to do, to try to help you be educated, and then reach out to your friends, your sisters, your aunties, and share this information, and make sure that our voices are heard.
I think that's so important to say, make sure your voices are heard. I think what we want to really talk about is self-advocacy and having that ally with you in case that you are worried about something, but also making sure that you access resources that are available. And so just to let all of you know is that there will be something emailed to all the attendees that'll have a list of resources that are talked about today. And so if you don't get it, just don't worry, you're going to get something from the foundation that'll be sent to you, and really use that as much as you can. And we'll make sure that these two sites that you just mentioned are part of the resources that are included. So we're going to move and shift to another area that's also quite complex, and I think that really is complex in many communities, but especially the Black community. I think mental health is something that people don't want to talk about, and that there's a stigma to discuss it. And so I was wondering, Keisha, if you could tell us, what do you think are the key issues that we need to help break down these barriers for both the physicians treating the patient as well as the patients and their ability to self-advocate?
Well, I think when we're kind of talking about breaking down the stigma, I think we kind of have to understand where the stigma comes from. And so we know that the first encounter that Black individuals had with the concept of mental health happened during the expansion of the European Union. We know that ethnopsychiatry, if anybody's familiar with that, was often used by Europeans to essentially problematize the behaviors, thoughts, attitudes, emotions of Black individuals because it didn't align with the way that they emoted, the way that they behaved, the way that they saw their day-to-day. And so that resulted in differential treatment. Horrific differential treatment. And so when we think about that as being like the root cause of a lot of the stigma around mental health, like fast forward to 2022, and there's still a worry about being labeled, being treated differently, being seen as less than, being, placed in a category where you don't actually feel like you fit. And I think that being able to kind of understand that, okay, this is really rooted in racism, it's rooted in colonization, and so the practice of mental health in and of itself has moved from some of the ethnopsychiatry principles that it started out as, but is still a fairly Western model of care. And so I think in order to break down some of the stigmas, the first part is really changing the way that we talk about mental health. I think when we talk about mental health right now, we talk about it in the area of challenges to mental health. We talk about diagnostic criteria like depression or anxiety, OCD. We talk about stress. We talk about the difficulties, when in reality, mental health exists on a spectrum where it can be both positive but also challenging. And I think when we are able to talk about mental health in that way, it kind of allows for there to be an awareness that's built around the ways that life stress can impact your movement along this spectrum. And that's sometimes why folks might notice that a particular situation that is happening today is impacting them in a way that maybe it wouldn't have a couple of years ago. And being able to make these connections through psychoeducation, either at the community level or on the clinician level, to begin to make this awareness known can allow folks to begin to move out of the silo that I think mental health creates. I think it's really this feeling like there's something wrong with me, I'm the only person that's dealing with this, people are gonna judge me because I might judge myself because there's a bit of internalized stigma that might exist as a result of things that you've heard in community, things that you've heard in society, ways that you might have seen people get treated. And I think it's definitely helpful to be able to understand that, yeah, there are these biopsychosocial factors that play a role in how it is that your mental health is being experienced and how you move across this spectrum. And the other piece, I think, is around representation. I think, we have sort of heard conversations earlier around the fact that in ivory towers, like hospitals or school settings, like there isn't a lot of representation, and that can be a real barrier to care. Folks that I've definitely seen in my private practice, working at the hospital, have come to me seeking out, at least in the private practice sector, looking for somebody who looks like them because they acknowledge that I worry that if I enter into a space with a clinician that doesn't look like me, they might not understand. They might label and judge. They might kind of approach mental health from like a hierarchical, kind of they're the experts and you just kind of follow along with what it is that they say, when in fact it's more beneficial to be able to kind of have conversations with folks that look like you because there's a relatability that's there. And especially because a lot of the folks that come into contact with the Reproductive Life Stages program at Women's College, which I'm a part of, their referral process comes from the community. Like it starts with somebody letting them know that the resource is there, similar to what was discussed before, and also being able to have open dialogue about mental health without labeling. Like we're moving away from the practice of labeling. Like we want to move towards understanding. And so all of the people in this room, like as you encounter, individuals that are open about their experiences, or even you being open about sharing your own experiences, that also helps to reduce some of the stigma because, as I said, it shifts away from this sort of, there's something wrong with me and nobody else will get it, towards a place of, oh, life stress actually plays a role? Oh, so I can feel anxious, but then also have experiences in the future where maybe I don't feel as anxious. Oh, there can be a difference. And so I think that those are some of the main ways that you can kind of begin to break down those barriers.
Keisha, you made such an interesting point about the biosocial markers, which made me think of what Lorraine talked about, in that chronic stress can actually lead to diabetes. Chronic stress and actually exposure, environmental exposures could cause fibroids.
Yeah.
And then these same things could actually cause mental health.
Yeah, there's an interconnection.
Yeah, with all of it. And so I guess the idea of, we think of diseases as what's happened to me and what have I done to do this, but in fact it is definitely an intersection of lots of your life experiences and exposures, as well as your underlying biological factors, right? Mm-hmm. And so how can women, again, self-advocate for themselves when they think that they're having something that they're not quite sure and they don't want to label it, but they want to be understood with their physician to be able to access care?
Well, I think it's really important for Black women to connect with allies, as was mentioned earlier. I think it's being able to kind of connect with somebody who can help you to be supported or to feel supported when you're having these difficult conversations. But also I think it's an opportunity for Black women to just be open and have a voice about what is actually happening to them. I think oftentimes some of the pieces that connect to mental health are kind of normalized as this is just the Black woman experience. Like the stress is just normal, the pain is normal, the fact that my back always hurts is normal, because of all of the different roles, and there isn't really, a check-in that happens around, oh, well, is this actually something that's normal, or is this actually something that I need to talk about? And so I think on a physician and clinician level, it's really important to provide a space where you're inviting those conversations. You're not necessarily asking questions like, what is your mental health like? Because that might be a question that folks might not be able to answer nor feel comfortable answering because of the stigma. Asking questions like, how is your body feeling? How do you notice your sleep is? Do you find that your thoughts are really busy? Do you find that it's difficult for you to concentrate? So you're kind of thinking about all of these mental health pieces, but you're asking the questions in a way where people might be able to respond to them easier, where folks might feel like, oh, okay, this is maybe something I can talk about because the conversation is being invited into the room. And so I think at a clinician level, it's important for us to change the way that we're asking questions, to invite the conversation so that folks who are in that space where they're saying, okay, yes, I want to have a voice, I want to talk about this, I want to see if there's other treatment options or if this is normal, whatever normal might be for you, there is that sort of collaborative approach that's happening, because I think the clinician level is just as important as the advocacy level.
And can you describe some of the programs at Women's that are being offered in this space, particularly about the trauma program, trauma therapy, and the reproductive life stages program?
Yeah, so within the reproductive life stages program, we offer individual and group psychotherapy, which is the same in the trauma therapy program. And when it is that we are sort of thinking about way of how these programs are being accessed by Black women and by Black communities, part of the work that the trauma therapy program has been doing has been in connecting with community-based partners. Like prior to me coming to the hospital, I was affiliated with Black Creek Community Health Center, which is the Jane and Finch community, as part of the Bridges to Moms program. And our supervisor, Audrey Taylor, who I feel like everybody probably knows, but maybe not, she reached out to the supervisor of the trauma therapy program in order for us to be able to get training. And through that partnership, we were actually able to offer the Resource and Resilient program at the Black Creek location at Jane and Wilson. And so that meant that, a lot of the racialized clients that were being seen that might not have otherwise heard of Women's College Hospital or been able to commute all the way down to Women's College Hospital now was afforded the opportunity to be able to have this stage 1 trauma group, a complex interpersonal trauma group, and learn strategies around how to manage their mental health. And so I know that TTP has been very proactive in connecting with other community-based resources, connecting with other clinicians in other areas so that the clinicians can provide the groups without necessarily having a clinician from Women's College go out to that particular community space. And I feel like that work, being able to make those connections, is really important. Also within the RLS program, because of the types of groups that we run, both in pregnancy and postpartum, we do exit interviews, and we've come to realize from our Black population that there are certain things that they don't feel like they can bring up. And so what does that mean in terms of the type of care that we're providing? What does it mean in terms of meeting the communities of these Black childbearing individuals? It means that maybe we need to make a bit of a shift. And so we're in the process of planning a research study that will look at the experiences of Black women through the program, like from triage to meeting with a psychiatrist to engaging in group or individual therapy until a year postpartum. That's sort of the end of our work with clients, to see if there are things that we're missing. Maybe it means that we need to have a group that just has racialized faces around the screen because we're only doing virtual right now for groups. Maybe that might afford an opportunity to invite some of those conversations about the impact that folks are feeling that race has on their perinatal mental health experiences. And so I'm looking forward to that. I'm very excited to be a part of that, and I hope that, at some point in the future, that's something that we can share in a space like this, because as was mentioned earlier, there isn't a lot of information on race-based care, and it becomes really important to kind of understand the Canadian experience, because sometimes we get compared a lot to the States. And our experience is not the same as the States on a variety of different levels. And so being able to look at the Black female Canadian data becomes extremely important. And so I'm appreciative that that's being reflected at Women's College.
Thank you so much. We're going to now go. We realized there were lots of great questions the last one, so we're actually going to give you a couple extra minutes here for people to ask questions. So there are microphones on both sides, so if people want to get up to do that, and maybe while we're waiting, Keisha, could you answer this question? What don't you want to be speaking about 20 years from now?
20 years from now, I ideally would not like to be talking about how access to mental health services is a privilege and not a right. I think one thing that we know has always been there but has become a bit more prevalent in the course of the pandemic is that mental health is like the biggest wave, so to speak, especially within the Black community, especially between the Black female community. And I feel like right now, as much as there is funds being allocated towards mental health, there's infrastructure issues. There's only so much space. And I feel like it would be amazing if in 20 years folks can access mental health care without having to access private services or deal with wait lists or deal with time-limited services, because there's a lot of us. There's a lot of therapists that are out there. It's just to try to make it work so that people are able to access it in an equitable fashion.
Yeah, no, totally. And I think thinking about how we can go to the community, like you talked about, right? How much can we go to the community to advocate for care?
Exactly.
All right, we're going to start here on this side.
Hello, good evening. My name is Kyla, and I've heard your panel and the panel before this one, and I think you guys have been providing really good information, so thank you. I do have a question. I realize that there's a common denominator here. There's social determinants of health, and I know that we're having a conversation about advocating for ourselves, and we're talking about stress and how that is a big contributor to these diseases or things that Black women are more prone to. So I'm just kind of conflicted as it concerns now adding another layer of quote unquote stress when it comes to, it seems as though we're directing the onus now back on the patient to advocate for themselves and like add another layer of stress. It's like instead of me just going to the doctor and telling my physician, these are my issues, now I have to add another layer and say, okay, I'm gonna advocate. And my friend here who had to go and request her medical records, I don't think that is enough or that is fair, because it's saying, no, you're a Black woman, in order for you to get the same service as a non-racialized person, you need to do extra work to get there. And that's it. I know that this is a solution currently, but I just see it as being a bit problematic. So while I do see this as an answer, a preliminary answer, and I'm not holding you guys up to the stake or anything, I'm just wondering, is there another way that we can ensure that everyone is accommodated, and is there a way to train clinicians from the outset to pay attention? Okay, I know I have a black patient. Her needs are going to be different to a white male patient, and so I'm going to be more sensitive to these issues as opposed to a white male. I'm thinking that these questions need to be addressed or raised among the medical professionals. And sorry, I know this comment or question is long-winded. I'm coming to a close, but I'm just making a comment. I'm a layperson, so I'm not well versed in the medical field, but I have heard that in the medical profession, in medical schools, maybe not all, but some of them were taught that Black people don't feel pain in the same way. So in the same vein that they can teach that, why don't they teach, okay, Black women or Black people are more exposed to this, or they're more exposed to that. I'm not saying that doesn't occur. Perhaps you can correct me or invite some points, but that's my concern as for the night. I'm finished.
Yeah. So I'm going to pass it to the panel a little bit, but I'm going to just start by saying I think that advocacy is actually really important for everyone, because what I'll say is that when people come into a physician office and you only get those few minutes, it's always hard to get everything that you need to get done in that short time, and that it's important that you advocate for your own questions, and this is really important for everybody. And I will say that even when I've had to navigate through the healthcare system for a family member who's also a physician, surprisingly, we actually also had to advocate in an inpatient setting and an outpatient setting for multiple patient safety mistakes that happened. And so I would say that self-advocacy in the healthcare system is important for everybody. Is it in particular just important for? No. But I think that we are trying to address those issues that you've raised. Medical school education does need to change, and it does need to make sure that we address these factors. And I think I'll pass it on to Sydney, who then will be able to start sort of talking about some of the changes that are happening.
Thank you so much. That I think is a great introduction to what I would like to share with you. Thank you for that comment. Thank you for your comments. Thank you for holding us accountable. That's why we're here. We want to, as healthcare providers, we want to know how we can shape and change the system for the future. So we're getting there. We're working on it. It's many different steps, I think, that need to be taken to respond to the things that you've just mentioned. The onus is not on the patient to have to do all that advocacy for themselves or, through their allies. It really is the whole health system that needs to respond to patients, to Black women. And so, for example, at our hospital, at Women's College Hospital, we have learning modules for all the physicians, and the modules now include teaching regarding anti-Black racism, indigeneity, respect for people of diverse genders. So it's being built into our ongoing education as physicians. And so all of us need to be allies to one another. If we're talking specifically about Black health and anti-Black racism, as Rulan was mentioning, the medical school curricula need to be changed. And in fact, that is happening. So at the University of Toronto Medical School, the Temerty Faculty of Medicine, there is a Black health educational stream so that all medical students are exposed to learning around Black health. For example, in dermatology, teaching around different skin tones and diseases that affect people of different skin tones and darker skin tones is included. I'm involved with a province-wide effort to address not only the presence of medical students that are Black in all of the medical faculties, but also making sure that they graduate and that they go on to do training to become physicians in different areas of specialty. It's important work. We call the network Enable, and it's basically a collective across all the faculties of medicine to support the resilience, the mentorship, the promotion of Black students once they arrive at medical school, because there's still not too many of us in the medical schools. It's getting better, but clearly sustaining and nurturing those students will be important for the Black health leaders of the future. So there are a lot of things that are happening. There's probably a groundswell, I think, of progress in terms of medical education, systemic changes within hospitals, within our universities that are looking at these issues. So we're getting there.
Okay, thank you.
Thanks
Thank
so
you,
much.
everyone. Due to such a robust panel discussion, we are only able to take one more question from the audience at this time.
That's called the voice of God. So let's go to your question.
I get the privilege. Thank you guys for being here. But this is sort of a comment and a question as well, because I feel like when we look at mental health, and we're not recognizing that we keep looking for a diagnosis. We're not looking at the struggle of a woman, of what can actually cause that, taking care of us, your children, working, maneuvering through all these different things. So I feel like in supporting Black women's health, we have to look at the things that we actually need to help them with, and that's creating clinics and support for them managing, because we're often left having to take care of our fathers, our sons, our brothers, supporting our mothers, and there's a big lack of support for Black men's health in our world, which actually falls back on Black women's health, because we're not managing and we're not knowing how to maneuver ourselves through the system or maneuver our sons, and it actually affects our health on a bigger scale as well. So if there are people in the room that listen to program development, that's something to consider, what we go through as Black women with children.
No, it's a fantastic question.
please welcome back Jennifer Bernard.
I think we're not quite. Can we finish this question? Can we answer one question?
that, if it's okay?
Yes, Keisha, please go, and then we'll answer.
I will wait.
Okay. So I definitely agree. Like, I think that when you're working with Black women, that there is definitely a need to focus on the things that make life difficult. And I remember when I was working in community, my role, as much as it was to provide individual and group therapy, was also to provide resources. Like, I feel like it was a very different experience being able to, make suggestions or provide resources or be able to kind of place the context of day to day, as you kind of said, like you're caring for, family members, you're caring for your kids. There isn't really space for you to care for yourself, and you can't really do the therapy to process the things that you're dealing with when you have all of this other sort of stress that's happening in your day to day. And so part of my work was really to kind of help in the best way that I could to manage some of those stressors so that there's space to be able to kind of work on the mental health pieces. And I definitely think that that is something that needs to be incorporated into more programs, because you're right, we need to shift away from diagnosis. We need to spend more time being curious about a woman's experience, be curious about how it is that they're responding to those experiences, and be able to try to support in the best way that we can. And so I definitely agree with you, like the wraparound care needs to be really important, as opposed to like the Western traditional model, which is let's diagnose, let's put in a treatment plan, which might include medication, and then you're kind of off, right, to do whatever it is, but you're not actually helping to deal with much of anything. And so I think that that's part of the decolonization of what it looks like in psychotherapy. I'm not a doctor, and so I know psychotherapy is a bit different in sort of this approach, but also sort of decolonizing practices within the medical field as well.
I really feel like the spoiler. Oh my goodness, we could be here all night. Backstage, you're like, oh, we're over time. I'm like, we have to let this ride. This is one of the most amazing discussions. Do you see why we needed to come here today? Oh my goodness. And why it is just the tip of the iceberg. So we're looking forward to your feedback and your input to make this better and better and bring it out into community and maybe one day across the country. And my wish is in 20 years, we no longer have to have this conversation. A big thank you, Dr. Parekh, our wonderful lead in academics and research, Dr. Lorraine Lipscombe, Dr. Cindy Maxwell, and Dr. Keisha. And you are right, we have to save Black women because we have to save Black men, and we are at the core of all of that. I forced my son to come. I didn't have to force him. He comes to all of my stuff. And it is so important that our men and our allies are part of this journey. So we're going to wrap up this portion. Again, I want to thank you all for coming. If you're staying for the Emily Stowe Society celebration, and I hope you are, this is exactly where we need to go. More researchers, more people on the front line. So we are not advocating for ourselves, but others are advocating for us and doing the research that we need. Our voices will be heard and ingrained in everything we do. If you're leaving now, I want to let you know that we are so privileged to have you here with us. And I'm gonna quote one of my favorites, Dr. Maya Angelou. You can't have an event without quoting Dr. Maya. And she says, so beautiful, each time a woman stands up for herself, without knowing it possibly, and without claiming it, she stands up for all women. Tonight, we stand up for all women.